Hi, my name is Dr. Garth Sliz, and on behalf of the ICM department, I would like to review the 6 cardiac murmurs that we will be reviewing during Skills Lab of Week 3. During that lab, we will focus on 3 systolic murmurs: aortic stenosis, mitral regurgitation, and ventral septal defect. We will also focus on 2 diastolic murmurs: aortic regurgitation and mitral stenosis, and we'll also include a combined systolic-diastolic murmur of patent ductus arteriosus. These murmurs, of course, are not all the cardiac murmurs, but they are the main left-sided murmurs, and by knowing the pathophysiology and sounds of these murmurs, then you will be able to translate those skills into the right-sided murmurs as well as the other cardiac murmurs in the heart. So a murmur is just a noise made by obstructed forward flow or leaky backward flow. So let's start with the systolic murmur of aortic stenosis. In aortic stenosis, the valve becomes diseased 90% of the time due to the calcification from aging of the valve, and 10% of the time it can be from the disease of rheumatic fever. Both of these diseases narrow and stiffen the aortic valve so that it obstructs the blood flow. As the blood is ejected from the left ventricle, it hits the diseased aortic valve, and this causes turbulence. The sound of the turbulence is transmitted mainly to the arch of the aorta. The sound of that turbulence, because it's in the arch of the aorta, is best heard in the right second intercostal space. This sound is radiant and can radiate to the left ventricle, and it can also radiate to the carotid artery as well. It is a harsh murmur that is medium pitched and has a crescendo decrescendo type pattern, which is best heard with the patient leaning forward because it brings the structures against the anterior wall of the chest. As we can see, the pattern begins after S1 and rises to a crescendo and then eases off to a decrescendo. This happens because there is a squeezing of the blood volume in the left ventricle, which ejects a volume of blood through that valve increasingly quickly as the squeeze happens. But then as the total volume is ejected, the rate of blood passing through the aortic valve starts to decrease. So the sound moves from a crescendo to a decrescendo. Let's listen. This is a pressure versus time graph from an angiogram of a person with aortic stenosis. I want to show you this because it's on the USMLE frequently. And as you can see, diastole, systole, and diastole. And during the systolic contraction of the ventricle, there's quite a high pressure. Usually the aortic pressure matches this, but in aortic stenosis, you'll see that the aortic pressure is a lot less than the ventricular pressure. That's the clue to this graph. So when you see it, if you see that the aortic pressure is much less than the ventricular pressure, you'll know that it is a case of aortic stenosis. The next systolic murmur I'd like to review is mitral regurgitation. This murmur is caused by the turbulent sound of blood leaking backwards through a diseased mitral valve. that is incompetent during systole. So instead of passing through the aorta, some passes backwards through the diseased mitral valve. This is caused by leaflet pathology of endocarditis or rheumatic heart disease. It also is caused by pathology from the annulus, from left ventricular dilatation of any cause. It can be from rupture of the chordae tendineae, from ischemia or endocarditis. This turbulence is best heard at the apex, and it does have some radiation into the left axilla. The murmur itself is a blowing, higher pitched murmur that is pansystolic. So if we look at this murmur, it begins quickly after S1 and lasts until S2. The steady murmur throughout. Because the left atrium is being loaded with extra blood from the retrograde flow, there is an S3 that occurs due to that extra blood being dropped into the left ventricle during diastole. Here's mitral regurgitation. You can hear how it lasts from immediately after S1 right until S2. But there was no S3 in that example, however. In mitral regurgitation, we can see that the ventricular pressure goes up during systole. The aortic pressure is staying up as well, so those are normal. But the left atrial pressure is good during the diastolic phases, but look what happens during the systolic phase. You see this steady rise of the left atrial pressure during systole. That's what tells us that the contraction of the ventricle is pushing blood back up into the atrium and causing that increased pressure. So that is a systolic murmur. Okay, so next is a ventricular septal defect, which is the next systolic murmur I'd like you to know. It occurs because there is a break in the septum between the two ventricles, of course, and this happens mainly at birth, but often can happen during damage to the tissue, likely from infarction. This gap allows high pressure blood from the left ventricle to be ejected through that wall during systole into a lower pressure area of the right ventricle. This turbulence is best heard because it's going from the left to right ventricle along the left sternal border in the 3rd to 5th intercostal spaces. Now this murmur is a high-pitched pansystolic murmur like a mitral regurgitation, but mitral regurgitation is a blowing murmur and this is a harsh murmur, and we'll listen to the difference in a minute. So with a pansystolic murmur like mitral regurgitation, it starts right after S1 and continues through to S2. Here is a VSD. Now listen again to mitral regurg, which is more blowing. And remember that the VSD is best heard at the left sternal border, and the mitral regurg is best heard at the apex, which is a key clue. So next is a murmur that is both systolic and diastolic, and it has a very distinct mechanical sound, and it is a patent ductus arteriosus. So the prenatal circulation has a connection to bring the maternal circulation directly into the baby's aorta, bypassing the lungs. And this ductus arteriosus closes postnatally, but in a patent ductus arteriosus, the circulation persists and high pressure aortic blood passes back into the low pressure right-sided blood. This is best heard along the left sternal border, and it is a very mechanical sound. Listen how it continues right through S1 to S2 and right through S2 through diastole to S1 again, making a very continuous machine-like sound. So let's look at our two diastolic murmurs. They are aortic regurgitation and mitral stenosis. When you listen to those, now you are trying to hear the sound after S2. So you hear the contraction of systole, S2, and then you hear the murmur. So let's look at aortic regurgitation first. This occurs when blood is leaking back from the high pressure area of the aorta back into the ventricle. And this can happen when the aortic root is dilated and therefore the valve doesn't close completely. It can also not close completely because there is a bileaflet instead of a trileaflet aortic valve, or then those leaflets can get damaged either from rheumatic fever or infectious causes as well. The backflow through a incompetent semilunar valve causes an early decrescendo type murmur. The flow is backwards, however, so instead of hearing it up in the normal aortic right second intercostal space, you hear it as the turbulent flow goes down into the left ventricle, so you hear it more along the left sternal border. And if it is really loud, you can hear it down into the apex. Both diastolic murmurs have special maneuvers that help. And with aortic regurgitation, if we get the person to sit up and hold their breath in exhalation, what that does is increases the systemic pressure, which of course would push the blood backwards through the aortic valve more, and leaning forward allows you to listen to the anterior part of the chest even better. So when you hear that maneuver being mentioned, you know that it is aortic regurgitation. It's a high-pitched blowing murmur, so like all high-pitched murmurs, it is best heard with the diaphragm, and it is a decrescendo type pattern. So it starts right after S1 when there is a high pressure in the aorta, and this decreases during diastole. As you listen to it, you can hear S1 distinctly, and then you can hear the murmur start just with S2. In aortic regurgitation, the left atrial pressures back down to baseline. But what you'll notice here is during the diastolic phase, there's a rapid drop in the aortic pressure here and here. During systole, the pressure in the aorta does go back up to the same as the ventricular pressure, but during diastole, you see this rapid phase drop in pressure. That's what helps you recognize that it's aortic regurgitation. The other diastolic murmur is mitral stenosis, and this is an obstruction of the forward blood flow from the left atrium down into the left ventricle through the mitral valve, but the mitral valve does not open properly, and it prevents and causes turbulence of the blood dropping down into the left ventricle. This is most frequently caused by rheumatic fever and bacterial endocarditis, and is often accompanied by an opening snap where the diseased mitral valve snaps open, and you can hear that just after S2. The turbulent blood is dropping into the left ventricle, so the sound is best conducted into the apex region. One can accentuate this murmur by asking the patient after exercise, which increases the cardiac flow, to lie on the patient's left side and breathe out, which makes this murmur louder. Now, this murmur is a rumbling, low-pitched murmur, so it would be best heard with the bell like other low-pitched murmurs. So we are listening at the apex and listening for S1, then S2, followed by a rumbling, low-pitched murmur, but this rumbling, low-pitched murmur is initiated often by this opening snap. Because the left atrium contracts just before S1, this fully loads the left ventricle, but you hear an accentuation of the diastolic murmur right before S1. Listen for the opening snap just after S2, so S1, then S2, then an opening snap, so it's like a bump-a-boom, 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 followed by the diastolic murmur. Note the low pitch. The graph for mitral stenosis shows that the pressure in the left atrium stays high, but as you notice drops during systole. So during the two diastolic phases, it is quite a bit higher due to the added pressure in the left atrium due to the poor flow from the left atrium down into the left ventricle. That's different than mitral regurgitation because in that case, the pressure in the left atrium goes up during systole, but in mitral stenosis, it's higher than normal during diastole and drops a little bit during systole. So this was our murmur review for our lab. I hope you feel it was helpful. If you see any mistakes or have any suggestions for improvement, I would love to hear it. So please let me know. Thanks very much.